You, please, it's your time. Thank you.
Good afternoon, everybody, and thank you to EuroELSO for inviting me to speak here this afternoon. I have no conflicts of interest. When we think about the nursing role, what do we think that the main aim of the nursing role is? Well, it's to manage the circuit and the patient's cardiac outputs to optimize patient physiology, but also to ensure the safety of both the circuit and the patient through the recognition, prevention, and management of complications. And for the focus of my presentation this afternoon, I'm going to really be focusing on the practical elements of the nursing care of VA patients. And so if we think about it, at the beginning of each shift, the ECMO nurse needs to do a tip-to-tip assessment, access cannula through the membrane to return cannula of the ECMO circuit. We need to be looking at for any clots, or particularly around areas of turbulence, any fibrin stranding, and that we have gun ties in place. As mentioned in earlier talks today, we're looking for a really good colour differentiation between our access and our return cannulas so that we can ensure adequate oxygenation and a good blood supply back to the patient. We want to secure our ECMO pipes so that we don't get accidental decannulation. So we want to secure the pipes to the bed, again, a safety measurement. We need to check our heater cooler, that it's on, that it's set to the right temperature. And then most importantly, we want to look at our safety equipment, our emergency equipment. So our syringes for de-airing, our clamps. Importantly, have we got a hand crank available and is it in the right position? Have we got a spare and full oxygen cylinder? So that if there is an ECMO circuit emergency, we're readily able to deal with it. And then we look at our ECMO settings. What are our revs and what blood flow is that achieving? What's our access pressure and our pre and post membrane pressures? And this will give us our delta pressure, our TMP. And clearly we want to continuously monitor this to get an early indication of potential membrane failure. On VA ECMO, we're looking at the SVO2 and obviously the temperature of the patient. We set the bubble alarm in VA ECMO because clearly we don't want bubbles entering the arterial side. And then with all our parameters, our access, our pre and post membranes, we set the alarms and the interventions. We record our observations hourly, and it's about monitoring the trends in the revs. Are we having to increase the revs to achieve the same blood flow? Because this could indicate a problem with the membrane, that there could be a thrombosis developing. So it's very important to look back over the shift in the previous 24 hours to look at trends to give us insight into if there's potential for membrane failure. We then want to look at our sweep gas flow, what's it set at, and the circuit FiO2. At Guy's and St Thomas's on VA ECMO, we don't ever set this at less than 50%, but that's just the practice in our institution. And then we look at the membrane itself for examining for any signs of fibrin stranding or clots. We want to make sure that our pre-membrane and post-membrane pigtails with the three-way taps are attached and secure. And it's from these that we will do daily pre- and post-membrane blood gases to assess the function of the membrane. Now, obviously, small clots are normal. Small clots, fibrin stranding, bit of marbling, that's normal, and we see this in our patients. But large clots such as this are not normal and will require a circuit change. So that's why it's terribly important that we're vigilant about monitoring the TMP and membrane resistance over time, and using this information together with the patient's blood results to give us an early indication that the membrane is starting to fail, so that we can do an elective circuit change and not have to do the circuit change in an emergency in the middle of the night. So our role as ECMO nurses The aim with VA ECMO is for the ECMO nurse to titrate ECMO blood flows to ensure adequate oxygen delivery to the tissues. We're at the bedside 24/7, and following the ward round, we will have various targets which we are going to try and titrate the blood flows to achieve. So we need to titrate the blood flows to get an SVO2. We're aiming for greater than 65%, and this will guide our titration of the blood flows. With the sweep gas flow, we titrate this on our post-membrane blood gas, and we want a CO2 of around 5.5 to 6 kilopascals. And again, we'll titrate, as the ECMO nurse, our sweep gas flow to achieve this target. Again, during the post-membrane blood gas, we will titrate the circuit FiO2 to target a PaO2 of 15 to 20 kilopascals. But as I said at the beginning of the talk, at St Thomas's, we never take the circuit FiO2 in VA ECMO below 50%. But then thinking about the lungs, what are we going to do there? Well, again, we want to titrate the ventilator FiO2 to target a right radial artery PaO2 of 10 to 15 kilopascals. Again, the minute volume, we want to target a right radial artery PCO2 of 4.5 to 5.5 kilopascals. And this is what we'll be doing on shift. So throughout our shift, we'll be monitoring oxygenation around the body. And this will entail us doing paired gases, so post-membrane gases and gases from the right radial artery, 6 to 8 hourly. And then we've got our targets so that we can titrate either the ECMO circuit or the ventilator. We monitor both cerebral and peripheral nerves. And clearly what we want here is a similar percentage recording in both the right and the left, because again, this will give us an indication of poor perfusion. We're monitoring blood gases on a right radial artery. We're monitoring our saturations on the right hand. And essentially, we're targeting a lactate of less than 2, ideally, and an SVO2 of greater than 65%. But it's not all about the circuit, is it? We've also got to consider the safety of the patient. And as was pointed out earlier, patients on VA ECMO have many complications, including all of those listed here. And it's our responsibility as the ECMO nurse at the bedside to know about the potential complications and to recognise them and manage them, hopefully, before they occur. So respiratory function in VA ECMO is often normal. And in fact, what we want to avoid is overventilation, whereby we ventilate too much and we'll get a local respiratory alkalosis, which will give an ARDS type of effect. So we tend to target an end-tidal CO2 of greater than 2.5 to 3.5 kilopascals to ensure that we're not overventilating. But sometimes lung function in VA ECMO is not normal. And we see this, obviously, in peripheral VA ECMO, and it's caused by recovery of the heart before, in the presence of diseased lungs. So the lungs are poorly perfused. There's either pneumonia or pulmonary edema or some other underlying etiology. So the lungs are poorly perfused. Well, when the heart is not ejecting, this initially doesn't cause too much problem because the ECMO blood flow can continue oxygenation around the body. But as you remember from earlier talks, in peripheral VA ECMO, oxygenated blood is delivered to the aorta via the femoral artery in a retrograde fashion, and it competes with the native antegrade circulation generated by the heart. So as the heart starts to recover, in the presence of poorly diseased lungs, there is a risk of a separate perfusion of the upper and lower parts of the body, resulting in coronary and cerebral hypoperfusion. So we need to be aware of this being a problem with peripheral VA and monitor for it. And if we look here, we can see the first branch of the aorta is the innominate artery, which subdivides into the right subclavian artery and the right carotid cerebral artery. So this is why we need to monitor our radial blood gases on the right radial artery and our saturations on the right side, and also why we monitor our central nerves. Here we will pick up at the earliest possible time if we have a deficit of oxygenated blood supply to the brain, and we'll see this discrepancy between the right and left cerebral nerves. So what can we do about this? It's mentioned earlier. So if we pick this up, then what we'll want to do is increase ventilation, either the oxygenation via the ventilator or the PEEP. We've obviously got to treat the underlying etiology that's causing the lungs to be poorly perfused and diseased. If the heart's recovered sufficiently, we can switch to VV ECMO until the lungs recover. If the heart still needs a bit more time, then perhaps VAV ECMO. So it's very important as the bedside ECMO nurse to be continually monitoring for signs of the dual circulation or harlequin. Cardiac function. Well, VA ECMO is preload dependent, as we've heard, and afterload sensitive. So what we're aiming for is normal sinus rhythm in an ideal world and a MAP of 50 to 55. And excessive blood pressure can cause problems for our ECMO forward flow. So if there's excessive afterload, we will lose our ECMO blood flows, and this is the problem. So what we've got to think about is reducing the systemic SVR. If the patient's on vasopressors, let's reduce the vasopressors, let's consider vasodilation. And if they still do require some vasopressors, we've got to be very careful when we're double pumping to change the infusions that we don't cause an excessive rise in the patient's blood pressure, which will result in a loss of ECMO blood flows. Pulse pressure, as we've heard, is very important. Loss of pulse pressure will cause a problem. So we're aiming to look for a pulse pressure to ensure some sort of cardiac ejection, because obviously, but if we lose pulse pressure, this could be due to excessive VA ECMO blood flows. So are our ECMO blood flows too high, and you've got the poor heart trying to contract against this retrograde blood flow from the ECMO circuit? If that's the case, let's reduce the ECMO support. We've got to maintain some kind of an intrinsic cardiac ejection to avoid intracardiac stasis and thrombosis. As we've heard, then we risk pulmonary edema, pulmonary hemorrhage, and potentially irreversible left ventricular damage. We can consider inotropic drugs, levosimendan, milrinone, dobutamine, GTN, or the balloon pump, as we've heard, or the impeller. Worst case scenario, atrial septostomy, and occasionally maybe conversion to central VA ECMO. So for patients who do have balloon pumps in, it's essential that we check for underlying pulsatility at least once a shift or more often if necessary. We may need to commence or increase inotropes, and the patient will require a daily echo to monitor for cardiac recovery. We've heard about the problems with distal limb ischemia and arterial damage. So again, we want to do our hourly neurovascular observations. We want to ensure where the patient has the backflow, the distal perfusion cannula in, that we have blood flow down here of at least 150 to 200 mils of blood to ensure adequate blood supply to the lower limb. We're looking at using the Doppler, colour, warmth, and capillary refill. Clearly, we've got our peripheral nerves that we're continually monitoring as well to tell us about blood supply to both the left and the right lower limbs. We also chart hourly the blood flow in the distal perfusion cannula, and clearly if we see this falling off, this is in a matter of urgency that we get this sorted as soon as possible. Otherwise, we risk losing all blood flow to the lower limb, and potentially in the long run, that could result in the loss of the limb. So we call our perfusion colleagues in as soon as possible to declot the distal perfusion cannular clot so that we re-establish perfusion to the lower limb. And finally, just a mention about bowel ischemia. And bowel ischemia is a problem in VA ECMO because of the low cardiac output states. So as the ECMO nurse, we've got to be monitoring for this, which is why we target our post-membrane blood gas, the PaO2, of greater than 15 to 20 kilopascals to ensure adequate perfusion to the gut. We're also looking for signs of malabsorption. Is the patient absorbing their feed? What's their intra-abdominal pressure doing? What's happening with the lactate? Is that climbing? And if there are any major concerns, we need to get a CT as soon as possible and get the patient to theatre. So I hope in that brief oversight, I've given you some idea into the key issues that the nursing management of the ECMO patient requires to ensure the safety of the patient and the safety of the circuit. Thank you.
Thank you so much, Kathleen. A really wide view of the ECMO patient from nursing point of view, but also from patient point of view, because you underline some complications that for the patient are very important, as the legs ischemia, for example, could affect the outcome of the patient, the life of the patient. So I think that we have finished our time, but for a couple of questions we have time. From the audience, we have a couple of questions to Kathleen. One is excellent presentation, compliments. In your role as an ECMO nurse, do you perform circuit change out if required? And what is the TMP number? I don't know, what is this? The alarms for a circuit change, transmembrane pressure, okay. So the question is about who change the ECMO circuits and which are the alarms about this. Thank you.
Okay, so in our institution, we don't perform as ECMO nurses the circuit changes. We are trained through simulation about how to do it, but we don't actually do it unless it is an emergency. So ideally, the ECMO consultant and ECMO fellow will perform the circuit change. And that's why I say that, you know, when we're monitoring for trends in the transmembrane pressure, the delta pressure, and if we're looking at patients' blood results, we want to pick up early that the circuit's failing so that all our circuit changes should be done in an elective fashion. However, if some circuits do occasionally suddenly go down, and in that case, the ECMO nurse in our institution on 2 occasions over the years that we've been doing ECMO has performed the ECMO circuit change with the ECMO fellow.
Thank you. Thank you. I'm just reading others' question to Federico. If the left ventricle presents a thrombus inside, it's appropriate to use venting to unload the ventricle in ECMO. What do you think about other way to change the method that you mentioned in presence of thrombus?
So first of all, let me remind that thrombus is stagnation, so per definition requires venting, and if you start ECMO in a patient who has developed LV thrombus, the thrombus is possibly going to increase, or at least the risk is significantly high. From the theoretical point of view, the best approach would be to go transeptal with a tandem heart cannula implanted in the left atrium, in order not to navigate the left ventricle. Nevertheless, that very much depends on the kind of left ventricle you are approaching, because if the ventricle is very large, the new 5.5 is without pigtail, is shorter, so you might safely implant the device. And actually I did some implantations of Impella in patients with left ventricular thrombus without any adverse event.
Okay, Thank you. I have a question, if we have time. Yes, 2 minutes left. To Thomas. Thomas, what do you think about implantation of ECMO, VA ECMO in that case, as a bridge to decision? This is, you don't mention about we put an ECMO because we don't know what to do with our patient. It's correct, or we have to avoid totally?
Well, it's not an easy question. I think, of course, you cannot avoid totally. There are patients where we don't know what the outcome will be, especially the neurological outcome. I think that is what you're talking about. So often you place patients during CPR on ECMO as a bridge to decision to see what will be eventually the neurological damage. And of course, the risk is that you have a high number of futile ECMO in these patients, which in the end can be very difficult for all involved, including the patient where you prolong suffering, including the family, also including the staff of the ICU, if you have many patients on VA ECMO who eventually succumb because they have severe neurological damage. So I think some form of pre-selection is necessary. If somebody has a high probability for a poor outcome, I would not put him on ECMO. If you don't know for sure, then you may put him on ECMO, if otherwise he has prognosis, and then see what's coming out in a few days.
If we have, yes, 1 minute left, a question to Martin. How to manage the cerebral perfusion during a prolonged VA ECMO? I mean, just with NIRS or other suggestions? And I think so we have finished our time. Thank you. I have lost no, it's muted. Unmute. Martin? Okay, we can finish. Thank you so much. I think that this is my conclusion. I suppose that our audience is satisfied by the speech. Particularly, we touch a lot of points in this 2 hours, and I would like to say thanks to my friends and colleagues and the speakers that participate today, from me and from the EuroAsso company. Thank you so much. Have a good evening and afternoon. Thank you.
Thank you, Mirko. Thank you to everybody. Bye-bye.
Bye. We're offline. Thank you.
Thank you.
Perfect.
Thanks.